Topic for webinar is specialized nutrition support in critical care case scenario. I thank Ms. Shobha, Chief Dietitian and HOD, Clinical Dietetics, Cloud Physician Healthcare Private Limited. Today's topic is specialized nutrition support in critical care case scenario. Case scenario, yes. I thank Ms. Shobha, Chief Dietitian and HOD, Clinical Dietetics, Cloud Physician Healthcare Private Limited, for accepting our invitation. See, she is an expert in this field. So here we have many students assembled. So the students in this group get to know the practical experience from Mrs. Shobha through the case study presentation. Welcome you, Ms. Shobha. To introduce today's speaker and the moderator of the session is, I welcome Ms. Lakshmi Jitendran, Assistant Professor, Department of Home Science, Mount Carmel College, Bengaluru, and Treasurer of NSI Bangalore Chapter, and a great technical support of the webinar series conducted by the chapter. Over to Lakshmi.
Thank you, Anand.
Thank you, Sindhavali ma'am. Okay, Shobha ma'am, can you just stop sharing? I will just introduce you, then you can share. I'll put your slide.
Sure.
Just
yeah. Thank you.
Yeah. Thank you, ma'am.
Yeah.
Okay. Good evening, one and all. So welcome to the webinar, one of the session of the webinar series, Knowledge Update from different expertise from the field of nutrition. So today among us, Mrs. Shobha, Dr. Shobha, Chief Dietitian, HOD Clinical Dietetics, Cloud Physician Healthcare Private Limited, is going to present the case scenarios which is related to enteral and parenteral nutrition. So it is my privilege to introduce the speaker for the day. Mrs. Shobha has 18 years of clinical experience as head of the department in reputed hospitals of Bangalore like MS Ramaya Hospital, BGS Hospitals, Narayana Hridayalaya and Sagar Hospital. She is the head of Department of Nutrition as well as chaired the National Hospital Nutrition Session Committee, Ada Referral Hospital, McGill University, Ethiopia. She is also skilled in independently prescribing and compounding of low-cost customized parenteral nutrition solutions that provide the complete and total nutrition support with complications and effective outcomes. She is also an expertise in handling enteral nutrition, especially nasojejunal, PEG, PEJ, feeding jejunostomies, etc. She has written training and reference materials and have done comprehensive modules in different fields of nutrition and nutritional management in organ failure and transplantation. She also conducts training in enteral and parenteral nutrition for neonates, pediatrics, etc. She also conducted many continuing nutrition education programs, CNEs, seminars, workshops, and national conferences. So today, ma'am, we all are waiting for your session. Over to you. Thank you.
Thank you. Thank you, Lakshmi. Thank you. Nice to join you all.
Ma'am, you can share the screen now.
Sure. Thank you.
Shobha ma'am, excuse me. Participants, kindly mute your audio and disable your video so that we can have a smooth conduct of the session. We can have a Q&A session at the end of the session. Once ma'am finished the presentation, we will have one question answer session where you can ask the questions and interact with the speaker. Thank you.
Thank you. Good evening, everyone. Myself, Shobha. I think Lakshmi and Dr. Sundarvali have given a very extensive introduction about me. Thanks a lot. I don't know how much of you have been hands-on experience of nutrition. I've heard the terminology, and on regular basis, we would have been using it in our practical areas or practice areas, what we call it as. I'll just give you an overview of enteral and parental nutrition. Then we'll go through the different case scenarios. The thing is here being many students plus practitioners as well. So I would like to give the introduction part to a brief and take the students, concentrate more on the students, because those who are experienced, are partially practicing or already practicing would be having a different approach to enteral nutrition, because their scenarios, their interests, and their way of approaching nutrition would be typically different. So from student point, because most of them I'm sure would be students, so from student point, how much you need to understand and what exactly we do at the practice point is very important. So enteral nutrition, enteral means it pertains to the GI tract, especially the gut. So if nutrition can be delivered through the gut, either orally or using a tube, any form of tube in any way, whether it is just a tube inserted, which can be removed easily with no surgical interventions, or tubes which are used through surgical interventions. So these forms of access to feeding are enteral nutrition part of it, like which we use most in the hospitalized patients, especially in critical care or ICUs or step down ICU. Through the scenarios, we will be getting a picture of how exactly we handle cases and how we modulate the diet. It's not a fixed diet, it will be more changing on daily basis. So nutrition delivered via the gut include, it can be oral and tube feedings. Nutrition support via tube placement through, either it can be placed through nose or esophagus or to stomach or to intestines, either the part of duodenum or jejunum. Of late, duodenal feedings have been stopped, and jejunal feedings are of more preferred when it comes to the post pyloric feeding. If gut is functioning, only then we use it. And if gut means if your GI tract is good, I mean to say the patient's GI tract is working, it is intact, and it is efficient in managing the nutrition, then gut is used. Unnecessarily, we don't go to use parenteral nutrition, which is an IV hyperalimentation. It's most of the time it is gut, which is always accessed, the preferred route of feeding. So enteral nutrition is initiated when there is an impaired ingestion. Ingestion means if the patient is not able to eat or swallow adequately, or if patient in case if the patient is not taking adequate nutrition or may not be able to take, or digestion is impaired, or absorption or metabolism, some of these things where it can be initiated partially, and I mean to say partial absorption is affected, partial digestion, or partially metabolism is affected, not total. If total digestion, absorption, and metabolism is affected and oral intake is totally affected, then we always consider parenteral nutrition. But if partially, if the system is able to, if the gut is able to support, then enteral nutrition is always the preferred route of feeding the patient. So enteral nutrition is always initiated in medical trauma, critical, neurological, onco, many of the areas. Just let us understand which are the areas or route of administration of enteral nutrition. This is just a pic like to show you. So either if you can just see the pic here, it shows like the feeding routes. If you take, either it can be nasogastric or nasoduodenal or nasojejunal. Like I mentioned few minutes back that nasoduodenal is not used of late, and most of the time either it is nasogastric. Most 90% of the hospitalized patients at critical areas do get nasogastric feeds. And nasojejunal is also minimum, especially if it is a short duration and acute pancreatitis or some clinical conditions where we use a minimum of sorry. The cavity nasal tubes goes through the nose into the stomach. This is the first preferred site, and 60 to 70% of the patients get this site to feed. Then comes your nasal cavity. You are going to use a gastric tube. Gastric, as my word itself mentions, the term itself says it is gastric feeding, or esophageal. Sometimes it so happens you can't feed the patient using either of the upper nasal or oral feeds. Orogastric tubes, if we can't insert, then it is esophageal tube also is inserted. Esogastric tube also is a very rare cases. Esogastric tubes are used. Otherwise, if it is surgically operated and patient needs a long-term nutrition support and patient will not be able to eat orally adequate, or if we can't use a nasogastric tube for longer term, in such cases, surgical interventions are done to put a feeding tube, and we always use percutaneous, it is peg feeds, or the radiological gastrostomy tubes are also inserted, or jejunostomy tubes are inserted either through endoscopic procedure or radiologic procedures. Peg or peg button and surgical gastrostomies are also on feeding jejunostomy tubes are also used. If you can just see here, if you just see the arrow here, you can see here the first site, preferred site is always the gastric side, the stomach, because it's one of the best and it is more physiological and it acts as a reservoir for whatever feed you give. So that is the preferred route. Apart from that, if you see the second one, it is usually the jejunostomy feed. So you're going to bypass the duodenum and feed the patient into the jejunum. The feed is delivered into the jejunum. Otherwise, it goes into the duodenum and jejunum. Usually, it is gastrojejunostomy. The sites can be at the jejunal sites. One or two preferred site would be taken up. And jejunostomy and gastrostomies are surgical in taste. So enteral nutrition tube. So when you plan a feed for a patient, if you are planning a feed for a patient, it is very important that you understand what enteral tube you are going to use. What is the base of the tube, whether it is a medical condition, clinical condition, or surgical condition for which the patient is being given enteral nutrition route. So the duration of the feeding, how long you're going to feed the patient using. If it is nasogastric, you can use it anywhere between 7 to 14 days or 1 to 2 weeks you can use. Otherwise, they will have necrosis and other problems can occur. So we usually think like, what is the time we are going to use, duration of feeding. In feeding access, what is the route which is given? And access, what is, whether you have to feed depending on the tube, the size of the tube, the rate of administration, and where the nutrients are delivered, whether it is delivered to the stomach or to the duodenum or the jejunum, where exactly it is delivered. This is also very important point. Why these points are important in following cases, you're going to understand. The size of the enteral tubes matters a lot, because in pediatric cases you can see between around 8, 10, or less than that, up to 12 sometimes you can see. And if it is gastrostomy tubes, it is called the lumen of the feeding tubes are very important, because this allows you to understand what should be the consistency, texture, granule size, and the thickness of the, or the flow, what we call the flow of the feed we are going to give. So if you are giving a thick viscous fluid, think, I'll just give you an example. If you take a milkshake, avocado milkshake, something avocado milkshake and watermelon juice or a tender coconut water. If you keep these three, watermelon can sediment. When you say clear liquids, it will be like tender coconut water. If you can give tender coconut water through tube 8 size, French size, it will not clog the tube. So the flow will be easy because there are no grains and it is very clear and there is no sedimentation. But if you give something like a watermelon juice, if you are going to give using a tube size 8 French size, that there can be the residue can stuck up. If it is not filtered properly, the residue can stuck up in this tube and the tube can slightly block or sometimes major. Think if you can pass through 8 French size tube avocado juice or something like milkshake, that will not pass. It will stick there only and stay there for long. So what is important is understanding the size of the tube, and the length of the tube becomes very important, because if you understand the size and length of the tube, then you will be able to understand how long the feed has to flow and reach the site of delivery, whether it is the stomach or whether it is your jejunum or duodenum, whichever the site it is, how far it has to reach, travel and reach, because this traveling also makes a sense. If you are not giving the right consistency, texture, or grain size, the traveling of the feed doesn't happen properly. It can clog and block the tubes also. So that can happen, especially medications also are delivered through these tubes. So it is very important for you to understand what is the size of the French size of the tube, or the lumen of the tube which is used, and what is the length of that. So that becomes very important. Then the site of delivery. Depending on the site of delivery, you should decide what nutrients you can give, what should be the texture, consistency, rate, and method of administration. You have to decide on this. As well as the monitoring parameters also are very important. Like I said, if you are delivering into the stomach, it's easy. You can deliver as much as you want, good quantity, uh, complete and standard formulas you can use, like your carbohydrate, proteins, fats, or whatever physiologically you eat on daily basis. That sort of a nutrients can be used when you are giving it to the gastric site, I mean to the stomach. But if you are giving it to the duodenum, again the churning or your physiological activity, what has to happen in the stomach, will not be taking place there. So it is going to the duodenum directly. So you are bypassing the physiological process of digestion from the stomach and landing up in the duodenum. So your digested products, partially digested product should be delivered to the duodenum. If it is again jejunum, again your bile mixtures, your GI secretions, consistency, the electrolytes in the duodenum doesn't happen. The pancreatic secretions, the bile, and other gastric secretions which are poured into the duodenum, and it is mixed with your, if you just go through your digestive process, you'll understand this thing. That doesn't happen with when it is delivered to the jejunum. So you have to give completely digested formulas and see that only partial digestion, the provision for partial digestion is good. And one more thing is that thing here is the bacterial contamination of the feeds. Or if feeds are not delivered to the stomach also, again, there can be problems with digestion, absorption, and feed contamination. And equally, patient can have feed related complications also. So should be carefully done. And there is no reservoir. Your stomach acts as a reservoir, and it keeps food for some time. But in case of duodenum and jejunum, there is no reservoir. Food doesn't stay there. It just keeps moving through the peristaltic movements. And this through the peristaltic, through the peristaltic movements. But you can't do bolus feeding in patients who are on duodenal or jejunal feedings. So the method of feeding these patients would be slightly different compared to bolus feeding or bulk feeding, what we call bolus feeding for these patients. So now, before feeding, you need to understand some most important thing from a dietitian point is your nutrition assessment. How do you do nutrition assessment? In most of the ICU patients who come for your enteral or parenteral nutrition are not mobilizable patients. There are exceptions, home-based parenteral nutrition in some of the patients. But in these cases, it so happens you don't get a patient's height, weight, and other things. And you have to still need it, not just from the nutrition point, even from the fluid, IV fluids, medications, the ventilator, the oxygens, the blood transfusions, many things. From many points, you need height and weight of the patient. So in case of an ICU patient, you can definitely calculate the height and weight of the patients using some of the measuring tips and standard formulas which are available also. You don't have to make the patient stand and then take their height, or make the patient stand on the weighing scale and weigh them. So you can use knee height or arm span and demi span and calculate the height of the patient. And you can use the mid upper arm circumference, and calculate weight of the patient. So I'll just leave the slides with your society so they can share you how to use this height weight of the patient. So taking those height weight, you always calculate the nutrition needs of the patients. So what nutritional assessment you should do for the patient, like your NCP nutrition care process may they always tell you, like you collect the anthropometric data of the patient. If it is not available, you have to use certain parameters and calculate them. Based on the anthropometrics, you're going to draw a conclusion, not just writing height, weight, and BMI, and that doesn't end. Then you have to draw an inference whether the patient is malnourished. If malnourished, what is the reason? Whether it is disease related, medicine related, treatment related, age related, or it is nutrition related. What is the root cause of malnutrition in the patient? What malnutrition it is? Malnutrition doesn't stop in hospital at the point of overnutrition or undernutrition. it can be surgical intervention. For example, if there is a short bowel syndrome, or recently we have a patient with gastrostomy and radical gastrectomy and ileostomy, and so many things have happened with them. These patients will not be able to metabolize proteins, I mean, digest proteins properly. So protein malnutrition can occur with this patient. Also, if gastrectomy is done, B12, vitamin B12 malnutrition can occur in these patients, because intrinsic factor synthesis which occurs in the gastric, in the stomach, by the stomach cells, that doesn't happen in this patients. So, and even vitamin K deficiency can also be seen in this patient. So it becomes very important for you to understand the type of malnutrition, the reason of malnutrition, the nutrient which can become a root cause of your malnutrition. So don't limit your malnutrition data to just undernutrition or overnutrition or risk of malnutrition. The goal of assessing nutrition status of the patient is to understand what type of malnutrition, what nutrient related malnutrition patient will have, and what is the duration, how you're going to manage this, and how you're going to prevent, and how you have to correct the status. So this is how you develop a nutrition assessment, and that is how you diagnose your patients. So then you collect the diet history of the patient. So why you need to collect the diet history of the patient? Because it's very important what type of diet the patient is taking, what were the meal patterns of the patient, then what is the meal format of the patient, what food frequency they are following, when is the last meal. These are very important. If the patient is being NPO, shifted from other hospital, surgical, into something like that, or what are the prescriptions that have been given, and what nutrition intervention was the patient on, whether the patient was eating orally, or patients may come with an enteral tube or a parenteral also, and changes in the meal formats, consistency, so many things. Then food allergies, intolerance, recent GE episodes, if there was any gastrointestinal episode, if the patient had recently, then if the patients are on any of the supplements like vitamins, proteins, nowadays it has become a fancy thing to take vitamin supplements, protein supplements, etc., like beverages and other things, herbal supplements, we see quite a lot of them. So you need to take information about all that and see how nutritionally it can have an impact on the patients. Okay. How it can have an impact on your nutrition status also, and sorry, on the patient's nutrition status. Nutrition related risks also should be taken into considerations. So what are the nutrition related risks here? Nutrition related risks can be like refeeding syndrome, aspiration risk, feed intolerance risk, then nutrition adequacy, whether the nutrition is adequate or not, micro and macronutrient deficiency risks, feeding concerns, drug, food, and nutrient issues. All this should be taken care of. So all these parameters and many more needs to be assessed before you start an enteral feeding for a patient. If it is a general patient and there are no much clinical issues about the patients, then definitely you can start simple enteral nutrition on physiological, kitchen-based physiological formulas can be fed to these patients. I'll just take a case scenario. I'll not go in depth into each case scenarios we'll take, and following that, I'll tell you about related enteral nutrition things like this. One case scenario. This is a 35-year-old woman with long-standing rheumatic arthritis. She was admitted with febrile neutropenia, presumably drug-related. Her body mass index, or the BMI, what you call, was 18.3 kgs per meter square, and on examination, she had severe mucositis was apparent. Lab showed an absolute neutropenia and a significant immunoinflammatory response. So, and electrolytes, renal functions were normal, and admission started on antibiotics. So patient was started on antibiotics, risk for refeeding parameters. So what I wanted to see here is patient is 35-year-old. I want people to interact. If you can open your mics and your cameras and interact and tell me what enteral nutrition thing would you like to do, and what are the findings you see here, and what formulas, if you are thinking of a standard formula or if it is a kitchen based formula, how we are going to start the enteral nutrition feeding.
Shobha ma'am, excuse me ma'am. Sorry ma'am, we have no disabled that option of speak.
Interactions. Okay, sorry.
We can
Sorry
have
for
sorry, we can have a
yeah.
Q&A session at the end, ma'am, so that no, like
Okay, fine. Okay, no issues. So, as per this, like as per this case, what we did means patient has refeeding risk. So, what are the parameters of refeeding we see here? Like potassium is low, sodium is low. Then we are going to look, this was the day one's finding, and this is the day 2, 3, like that each days it goes on. On the day one, we saw that sodium was slightly on the normal side, potassium on the normal side, calcium on the near normal side. So when we see the first day's reading, it looks very normal, but the day 2, it was reducing, like sodium was little different, potassium reduced, then we had calcium going down. So like this, we had, sorry, magnesium going down. So we started seeing a difference in the labs. That showed us because refeeding can start anywhere between day 1 to day 5. The window period of refeeding is day 5. So it can happen anywhere on the day 5, up to the day 5. So you should never assume, okay, today's parameters, lab parameters, and patient is fine, then everything is fine. No, patient can have refeeding on the day 5 also. Cardiac events and other complications can, morbidity and mortality of the patients can increase with refeeding syndromes. So before feeding of this patient, 3 things were supposed to be noted. So when was the last feed of the patient, and BMI being on the lower side, and drug-related febrile neutropenia. Patient is already having neutropenia. If you just go into the nutrition part of it, we don't give a neutropenic diet for this patient because neutropenia and patient is having fear. It's not like that. Yeah, it will be like you're going to give a normal feed, but the carbohydrate load of this feeds would be controlled. So per feed, you are going to control the carbohydrate load first thing. Second thing, adequate amount of hydration would be given. So free water can also be given to this patient through the NG tubes if NG is started. Then we'll have a protocol to prevent and monitor refeeding risk, any of the cardiac events and other refeeding related risks we are going to see there. And electrolyte imbalance, which is notable, which starts projecting on the day 2, 3, 4, that will be corrected, and thiamine will be initiated for these patients. Thiamine electrolytes, potassium, phosphates, and magnesium would be given. And feeding protocols will be slightly different for these patients. So generally, it's not like you go get a kitchen feed and pour into the tube and patient will tolerate. That never happens. Most of the time, in most of the ICU patients, you should always be sure that at least day 2, 3, the patients tolerate the feed. Only then you go on increasing. You have to go a little slow with the patients. This is a case scenario 2 I'm taking. The 66-year-old woman was diagnosed with metastatic commercial cell carcinoma of the anus and admitted for initiation of palliative chemo. Here there is no initiation of surgical intervention. It is directly patient is getting into the palliative chemotherapy. And chemo has got a lot of adverse reactions, and patients can have a lot of nutrition related concerns also with chemotherapy. So over the last 4 months, she had lost almost 12% of the body weight. So usually we take it as 10% and above means that means patient is going into severe malnutrition. So aggressively, you're not supposed to feed the patient. Since patient has lost 12% of the body weight, that doesn't mean you have to aggressively start nutrition and patient is on chemo and patient is having cancer. You will always think like high protein, high calorie, high vitamins, antioxidant diet, all that you should not do for this patient. I'm telling you clearly. So nutritionally, when you start for this patient, it's going to be small feeds, safe and stable till the patient is stable. So you're going to go with small amounts of feeds. Physiologic one, you're going to take into consideration the age of the patient. Second, loss of body weight and BMI going into the lesser level, and palliative and fecal formation should be one of the concern here. Because cancer of the anus, again, if you are feeding the patient's food switch, like don't rush to feed the patient probiotics or prebiotic foods or your dietary fibers, what you call the carbohydrates and other things. Again, that will be controlled for this patients because it's very important to control those things. These can again worsen the complications or infections if there are any. So that is another thing. So, and refeeding risk also can be noted for this patients. This patient, refeeding risk syndrome is also on the higher side for this patient. So we're going to start small amounts because we don't want the residue. Residue doesn't mean it is only the feed residue. It also means the gastric secretions and the what do you call them, gastric secretions, the enzymes, the hormones, gastric hormones, the food, the glucose, whatever is secreted into the system, that should be reduced. So you are not going to stimulate the stomach too much, feed too much to the patient. That should not be done. So what exactly I mean to say here is, even if the patient is an onco patient and she has lost a lot of weight and she's on chemo, you should not rush to feed the patient high calorie, high protein, and give the patient fiber rich food, so that and antioxidant rich, all that you're not going to do here. You're going to start small quantities and safely for the patient. Despite any supportive therapy, the treatment was poorly tolerated. So, see, because of malnutrition, one, because of the age problem, patient is not tolerating the chemo. And most of these problems are noted in chemo patients, especially onco patients. I mean to say, who undergo chemo, if they'll start losing weight, they if the higher the percentage, I mean, sorry, towards the, if their graph of weight is towards the malnutrition and they have a tendency to lose weight, the tolerance to the treatment will be very poor. So it's very important, like, to understand that part of it also, because these are strong medications and they can have their own complications also, the other complications which can come in. So we try to start the patient on a small amount of feeding so that the tolerance becomes better, and residue, gastric residue, what we call, should be little lower on the side, and no neutropenic diet and other things here. It will be directly you're going to start NG feeds, or if because patient is already having gingivitis and eating habits are very poor, so we would start with a little bit of parenteral also. And small, the rate of a parenteral feeding would be not 30 kilocalories or 40 kilocalories. It would be around 18 to 20 kilocalories per kg per day, and we are going to alter it accordingly. Slowly we are going to increase it. Why we are keeping so low calorie? Because though patient is a cancer patient on chemo, has lost weight, she needs more nutrition, she needs high calorie, high protein. All that doesn't work out in this patient, because you'll complicate the patient, and patient can have a lot of nutrition mediated complications which you need to prevent. So starting small quantity of feed here, it says that uh, you have to identify refeeding risk parameters. That is what I told you. One is weight loss, the other is age of the patient, low BMI, intolerance to the therapy, anorexia, all this puts into, and patient has not eaten anything last 5 days. That's the reason why I told you, like, at the point of diet assessment, you need to pick up the last meal. When was the last meal? What was it? Whether the patient tolerated or vomited the thing, like had a loose stool or something like that, you need to understand, so that you understand the feed tolerance. If patient was not able to eat, not tolerating, had a GE symptom or something, then you are not going to initiate immediate NG feeds or oral feeds. You're going to take a little time for the patient to settle, and then you start the feed. So that is important. And preventing refeeding risk becomes important. And you need to have a monitoring and prevention protocol in place. And feeding protocols, a different feeding protocol should be initiated for each patient. Patients like this. That's the reason why we started a small amount of parenteral nutrition. Slowly we went on altering depending on the number of days. The next one is a nutrition assessment. Like, this tells you like how much you should, what are the things you should consider when you are doing a nutrition assessment. Actually, I wanted an interactive session, but anyway, I'm just giving you the answers. Maybe at the end we can go back and have a little bit of discussions. So this patient, a male patient, admitted with pneumonia and swallowing difficulty. Pneumonia, again, you know, it affects the lungs, and lungs are very much needed for your carbohydrate metabolism. But since here pneumonia, if it is chronic, and swallowing difficulty, if the patient is having, definitely nutrition score would be poor. So if you are using either a MUST or a SGA scoring sheet, usually we use Nutrix score for ICU patients, but I do prefer to do as case-based, individual case-based, rather than using some standard which you can't apply for the ICU patients in common. But more majority of the population of hospitalized patients, you can use an SGA or a MUST screening tool, but good to go on an individual basis, which always give you much more information and clarity of what nutrition support you need to give the patient, and what type of nutrition or malnutrition the patient is having. So this patient had a MUST score of 5. So if you have the habit of doing some MUST sheets, mini universal screening tool, this is called as malnutrition universal or mini universal nutrition screening tool. This is which has a different category. If you just go on to the PAPIN site, you will definitely get that, can use it. So this patient weighed around 64 kgs and he was around 173 centimeter tall. He had lost almost 12 kgs in the last 6 months due to loss of appetite and inadequate oral intake. Because swallowing difficulty hai, so patient will not eat adequately. That is one thing. With pneumonia, the metabolism and the breathing patterns would change, and the respiratory quotient or the oxygen uptake and the carbohydrate metabolism would be affected. Obviously, patients will definitely lose weight and their appetite also reduces. So a speech pathologist was placed for him, and the patient, usually when they have swallowing difficulty, we try to understand what is the stage of dysphagia, stage 1 to 5, or sometimes some of the references give you stage 6 also. At least 1 to 5 stages are there, and these stages may we try to understand which stage of dysphagia this patient is having. And based on the type of dysphagia or the stage of dysphagia is of different. One is functional and the other one is mechanical. But depending on that, we are going to decide what type of feeding should be done for the patient, or if it is stage 3, 4, and if patient is not able to take, then we are going. The patient will be either on an NG feeding or the patient may go into the PEG or the PEG feeds. So this is two tube feedings. So depending on that, depending on the stage, the patient would be. So what is the So what is the nutrition and medical risk with this patient? See, if patient is having swallowing difficulty, he may not swallow it properly. And again, the feed residue can land up in the lungs, causing aspiration. And with pneumonia, patient's aspiration risk is on the higher side. Even apart from that, even with the age also, patient is having aspiration risk. And patient has lost weight also because of inadequate feeding, because he's having problem with swallowing. So they had done a swallowing test. A speech pathologist usually do this test. They give water, they give thick liquids, they give kanjis or soups, whatever it is, and try to find out which patient is able to swallow comfortably without having pocket mouth. They should not have pain while in the mouth, or should be adequate and comfortable enough. So depending on that, they are going to decide like what is the stage of dysphagia, or what is the comfort type of consistency, texture, and temperature the patient can tolerate. Based on that, you can decide like what type of feeds you're going to give the patients. So that is very important. But this patient did not find comfort with oral soft or normal diet, but he was able to take moderately thick liquids. So like soups, ganjis, custards were the one things those you can give for this patient. So management of risk protocols here is further weight loss if patient is not addressed becomes important here. So methods of administration, based on all these things, what are the methods of administration of enteral tube? It's not just the NG or NJ or PEG or PEG. Like how do you use? There are different methods used. The usual regular one is the bolus method, which we usually use, the bolus one. Bolus is like you take a syringe, a 60 ml syringe, and 50 ml is accounted for that. They use a syringe. The feeds are delivered via syringe in 5 to 20 minutes. So the by each patient might need, depending upon the volume and the consistency of the formula, they may take around 5 to 10 minutes. Mostly used in hospitals, but it is not used in general. I mean, it is not used in critical care patients or clinically unstable patients, but small amounts are usually used, but not recommended in case of pump using. You don't use a pump or a feeding tube. So, I mean, sorry, an enteral feeding bags or something like that. You're just going to give it. And this can cause bloating and abdominal discomfort also. And patients' gastric reflux can occur, and GRV or gastric residue volume can increase. Intolerance can occur. Aspiration risks are on the higher side in this case. Next, continuous drip feeding you can have, or intermittent feedings also you can have. Continuous drip feeding is you use a feeding bag to which you add the enteral formula. These are usually standard formulas are added, but sometimes even the kitchen formulas, if you are good and at preparing these formulas which can flow, the consistency and temperature and granule size can be managed with this. then you can use kitchen feeds also to be delivered through the feeding bags. So this is necessary, especially drip feeding we do in case of jejunostomy feeds. And if there is high risk of aspiration, feed intolerance is there, in such patients, we do continuous drip feeding like 100 ml per hour, 50 ml per hour, 20 ml per hour. If patients are having refeeding risk, we start with 20 ml per hour and slowly advance the rate depending on the patient's stability and medical condition and feed tolerance. Intermittent feeding is you give 3 to 6 feedings per day. You can administer over 20 to 60 minutes. Here also you can use the bag or gravity feeding you can do, and you can initiate around 150 to 200 ml, give a gap in between, or feed breaks what we call. That can be given and the next feed can be initiated. You can use pump and gravity methods also here also. So administration positioning of the patient is very, very important. It's important to reduce the gastric reflex, gastroesophageal reflex of the feed, which results in aspiration, and to prevent aspiration and better tolerance and better movement of food down the pylorus. For that purpose, we are always insisting on head end elevation of the patient. So HOB means head end elevation of the patient. Practical recommendations is you should always keep the patient at least minimum 30° or preferably 45° head end elevated, so that better tolerance would be there and you prevent aspirations. So and any unless the patient is contraindicated to head end elevation, there are certain clinical and medical or surgical conditions where you can't elevate the patient head. Patient needs to be on lying back if they have some spinal issues or pelvic or some head and neck issues. In such conditions, traumas and such conditions, you may not be able to elevate the patients. And of late in COVID patients also, if they have acute respiratory distress and they need a prone position, if the patient has to be prone, you can't do an head end elevation in prone position. So it becomes very important how you feed this patient. Small amounts with the breaks you're going to do. Patients will be on ventilators or NIVs, and NIV may again aspiration risk could be one of the things. So you need to always keep the patient in a condition where you don't overfeed or where you don't cause any aspiration risk or complications, feed intolerances. So you need to understand what is the state of the patient, how we are going to feed the patient, and how we are going to prevent complications or gastroesophageal reflexes or intolerances or distensions and other things. So you can, in case if you are not able to elevate the head end, then you can always use reverse tendon position. That also can be, but if it is contraindicated, again, you can't do that. It's most important to always keep the lower procedure so that patient's head end can be elevated and you prevent aspiration or gastric reflexes. Water flushes are very important. We do give additional water wherever patient's hydration is poor or patient has GE problems or patient comes with electrolyte imbalances. In some of the electrolyte imbalances, you need hydration. So patients can be hydrated adequately, and cleaning the tube becomes very important. Cleaning the tube doesn't mean you remove the tube, put some soap and solution and wash the tube. You need to just flush the tube with 5 or 10 ml. If there is no fluid restriction, you can give adequate amount of fluid and flush the tube. Using syringes, you are going to just push it. If tubes are not cleaned, what happens means bacterial contamination, feed contamination, bacteria growth in the tube can occur. And if there are medicines delivered, these medicines can go clog on the tube and tubes can get blocked. So those things can happen with the feeding tubes also. So it becomes very important to flush the tubes or maintain tube patency. So using sterile water, immunocompromised, especially in immunocompromised patients and critically ill patients, it's very important to do. Medication administration through the tubes also should be carefully done. So nutrition recommendations in case of enteral nutrition. Most of the guidelines tells you give 30 to 35 ml of fluid and you give energy, high energy, proteins, fats, fibers, micronutrients, and you take the form of the nutrients like you give whey proteins, you give soya proteins, or you give whey isolates, and what else? Many different forms of proteins are being recommended, and fats also. MCTs are recommended. Of late, I see a lot of them prescribing MCTs. I don't know the reason. Then fiber also, fiber supplements being given, and micronutrients, left and right micronutrients are prescribed. There are a lot of harms. More than doing good, you are harming the patients. So that should not happen. Always your energy should be to the physiological needs of that patient in the clinical scenario. Not like you take 30 as a standard, or not like you take 40 because patient has lost weight, but you have to go slow, build up properly, and once patient is stable, only then you should address the malnutrition. And form of nutrients, whether it should be a standard form or a physiological form or pre-digested or semi-digested formula, that depends again on the clinical. How much is the adequate becomes very important, and how the patient is going to tolerate. For example, if you have a patient with a peg feed and you want to give a semi-elemental or elemental formula, patient, if the patient is not able to tolerate, for example, if I go back to the case 3 in this patient, this case 2, if I take this patient, if I want to give this patient NJ feed or jejunostome feed with a peg or something like that, if I give the patient, because patient is not tolerating weight loss, so I think let me give this patient jejunal feeds and elemental formulas I'll give, or semi-elemental formula, this patient will not tolerate. Why? Means patient feed tolerance will be poor, because these elemental formulas are having high osmolarity. And when the osmolarity of the feed is on the higher side, definitely patients will end up having loose stools. And with chemo medications, patients will always have GI disturbances. So most, and elderly patient, so patient is on palliative care, and in that patient, if you give an enteral formula, which is an elemental or a semi-elemental, patient will not be able to tolerate, and they will end up having loose stools because of high osmolarity of the feed. So you need to understand which feed fits that patient, which feed is safe for the patient, which nutrient content will keep the patient safe. That understanding is very, very important. Consistency of the feeds are also very important. Formulas which you are going to use, whether it is kitchen based formula or a standard, not necessarily always you use a standard formula from some standard nutraceutical company, whether it comes in Abbott or a Nestle or Hexagon, not necessary. You can use kitchen based formulas also. Comfortably you can use, provided you know how to modify those formulas, the cooking methods, nutrient combinations, and the food combinations, which really helps you manage the nutrients and adequacy also, and safe also. And it can be close to physiological, and patients will get much better compared to standard formulas. That is my experience. Feed compositions and other things. Feeding regimens can be either intermittent, bolus, continuous, or you can use ready to hang formulas. Nowadays, this has taken over. Ready to hang formulas, you take a bag and feed it. But you never go back and see what are the composition of that ready to hang bag. What is the nutrient composition? What is the load? What is the osmolarity? How I'm going to feed the patient? Whether the patient is going to tolerate this feed? Whether this composition of nutrients suits the feed? Or whether the ingredients used for preparation of this ready to hang bag, those ingredients are fine for this patient. You need to go and look into these things and then decide. The root understanding of the nutrition for enteral is like you understand from where it comes from. Only then you decide whether it should be given to the patient or not. Then medications also, it's very important. Don't think a dietitian's job is not medication, it is only food. If I deliver, it is finished. Please don't conclude. Medications becomes very, very important, because most of these patients who come to the ICU or hospitals will be on polypharmacy, means more than 5 medications at times. And these not just drug interactions, even drug nutrient interactions are many. It's not just always warfarin or something like that, acetone or warfarin, whichever is given. It's not always those things. There are many other medications. Every second, third medication will have a drug nutrient interaction. So you should be always alert whether the nutrient will have an impact on the drug. For example, dietitian is one of the medication given, or even a simple one will take diuretics. If you take furosemide, if you take, it can remove potassium from the body. It leaches us because it is used as a diuretic. It can remove potassium. So if you're not alert about the potassium load in the diet, patients can have hypokalemia. Patients' potassium load can reduce. So it becomes very important. For example, the other one is the other diuretic like spironolactone, which can increase potassium in the blood. Serum potassium can get elevated. So you need to be alert whether what medication is given, how that will have an impact on the nutrient composition of the patient. Patient's serum or physiological nutrient changes can occur. So you need to think from that point also. Even if the patient is getting a normal insulin also, you need to be alert about the carbohydrate, the fiber, the gap between each of the meal, and what type of feed you are giving, how you are going to alter. And for example, if the patient is on Lantus in the early morning hours, there is a risk of the patient going into hypoglycemia. So you need to be alert what feed you are giving to the patient, how you are going to modify this feed so that patient don't get into any nutrition related complications. I'll just leave this slides because the first one we discussed about what to be done and all. So case 2 also. And how do you select the formula? Formula's selection will be based on the function of the GI tract, how adequately it is functioning, how it will tolerate. Then the physiological characteristics of the formula, like I told, osmolarity, fiber content, calorie density, and viscosity of the feed, all this should be taken into consideration. Macronutrient ratio also, the carbohydrate to protein to fat ratio, how it is, and whether this ratio will tolerate for the is tolerable for the patient in this clinical scenario. Digestion and absorption capacity of the patient, specific metabolic needs, and contribution of the feed to the feed and electrolyte needs or restrictions. If patients come with some of the cardiac disease and pulmonary disease and renal disease and liver disease, you may have to restrict fluid. If there is fluid restriction, how you are going to balance the formula? Think if the patient under normal condition needs 2000 ml fluid, but if the patient comes with fluid retention and you want to give only 1000 ml, then how you are going to meet the nutrition? If patient is getting full volume, you can give full nutrition. If patient has a restriction, then how you are going to? You need to increase the calorie density of the feed. How we are going to do that in such a way that patient should tolerate the physical characteristic of the formula should not be disturbed. And cost effectiveness is very important. Don't always rush to the pharmacy to get a formula and feed. Always think from the kitchen and then go to the pharmacy. If you're not able to make up the kitchen feeds, only then you need to go to the pharmacy. Nutrition needs and feed calculations. Always start enteral and parenteral calculation with the fluid load. First, you start with the fluid because it is a fluid-based feeding what you're going to do in the enteral and parenteral. Once you finish your calories, calculations, and proteins and carbohydrates, you start with fluids. If you are taking a fluid, actually, I wanted to give this as a calculation, but anyway, you can later take this and calculate and see and do it as a experiment or whatever your case study sort of thing. I'll just give an idea like if you're taking 2000 ml and the energy is 1600, so per feed per ml calorie would be 0 0.8 calories or less than that it will be. So you need to understand per ml how many kilocalories you are giving, how many grams of proteins comes and how much of carbohydrate comes. This is very important. So this makes you understand per ml calories will have an impact on the osmolarity of the feed. So to calculate that, you need to know the weight of the patient, not just the weight of the patient, feed tolerance also. What are the IV medications going on, IV fluids are going on, what dilutions are used, how much of tube patency you should use, and how the fluid should be managed. For example, if total fluid is 2 liters, then tube patency, especially the tube flush and medication, tube flush, you need around 2000 ml and medicines 100 ml if you are taking, then total 300 if 300 plus 1600 calories. So total it will become around 1900. So 1900 means approximately 2000 ml you can give through that. So using this understanding of total fluids, from where all the fluid is coming, plus how much fluid I should give as a allowance through the enteral tube is very important. So those things you need to consider there. So monitoring and documentation of enteral administration. How do you monitor and document? It's not like NG feed 200 ml secondary. That is not your monitoring or documentation. You have to understand the for tube placement verification, whether it is done using X-ray or mark point of the tube. Sometimes they'll mark, the nursing will mark on the tube. They'll put a mark, yes, this is where the tube is. So you need to understand sometimes. X-ray is very important. dietitian should make a point to check the x-rays at least. Go and see whether the tube placement is right or wrong. So ask for an x-ray if it is not done. Be alert always, because you're feeding, you can complicate the patient if you have not checked all these things. So when you're documenting, you write, yeah, the tube is right in position. Second, head end confirmation, whether the head end is elevated at the time of feeding or not, yes or not. If it is contraindicated, why, and how you're going to manage aspiration or GARD. If and observation of any signs of intolerance, if you see in the patients, whether distension or firmness or discomfort, nausea, vomiting, anything like diarrhea, other things, you need to mention it, and you have a consent with the primary physician, and find out the root cause of intolerance, whether it is medical related, clinical related, drug related, or feed related. Find out all these things, and then you find what interruptions have been done and how you are going to manage. Then ensure adequate mouth care. See, patients being on NG feeds, they will not be considering mouth care. Most of the time, nursing do this, but as dietitians, you need to know whether mouth care is good, because if mouth care is not good, the patient can end up having bacterial contamination. The bacteria from the mouth can pass into the esophagus and stomach, and it can cause problems to the patient, because these patients will be on antacids and bacterial management would become a problem. So you need to be clear of that. If it is not done, feed contamination can occur and patients can end up having GI disturbances. So very important point. Then document if there is any gastric residue volume, and you should always document all these things. Then verify tube placing every 8 hours. Find out every 8 hours from the nursing whether they have verified the tube, how they did they aspirate the patient and see, or auscult the patient and see, or ask for an x-ray and see how they have done the verification of the tube position. That also becomes very important. So weighing the patient on at least, if not daily, at least alternate day or once in 7 days, if you weigh, you will come to know if there is any fluid retention or feed retention or any problems with the patient, or weight loss and other things can be definitely noted. Then you have to document the volume delivered for each tube flush. This is very, very important. If patient is having fluid restrictions and you are not taking care of how much of volume is used for tube flush, then it becomes problem, because later on at the end of the day, fluid accumulation can occur within. Fluid overload status can become a concern here, and again you are going to reduce the feed load. So you need to know the tube flush also, the quantity of water used to flush the tube. Then document all this, and each nursing shift they would be documenting some of this points. So you should pick up from there. Always speak to the nursing and check what is the concern, what are your concerns, and your documentation should be. And the volume of the formula delivered should also be documented, and if there are any protein supplements being used, that also should be documented. So your documentation should not be limited to that one sentence of NG 200 ml secondarily or something like that. It should have all these things in the document in your nutrition notes. So monitoring is like you monitor the, apart from the documentation, you're going to always see what problems patient might be having, what are the risks, nutrition related risk or disease related nutrition risks or treatment related nutrition risk, how you are monitoring, preventing them and monitoring or correcting them, and how much nutrition is adequate, whether there is any calorie debit or you need to correct it, or if there is any physical assessment like edema and other things, how you are managing it, how much fluid load you are keeping, and how salt and protein status you are maintaining. Protein is very important in edema, not just salt and fluid. If you correct protein status to a greater extent, you can manage edema also. Then GI intolerance like feed, stool frequency, consistency. If there is ostomy output, then how much fluid you are going to manage. Then abdomen distension, pains, any nausea, vomiting, residues. You need to look into all this, and glycemic control also. All these are very important. And fluid intake, output, weight. Look at the trends of the weight changes. If there are lab data on regular basis, you can always ask for the labs. If you feel there is some issues or concerns about nutrition, you can always request for the labs also. Then review medications. If there are any change in the medications or some of the medications tapered off or some new medications added, you should see all these things. Then medical procedures, if there are any, and if there is any discontinuation request for the feed. So all these things should be done. Based on the orders, you can just, this is just a summary of all the thing what I mentioned here. Then concluding, what is important in enteral nutrition is you do assessment and reassessment is very important on almost every other day. Then feeding risks and complications, how we are going to prevent and manage them. And drug, nutrient and food interactions, not just food drug interaction, it is drug, nutrient and food interactions, because drug and nutrient together, they can have an impact. How we are going to prevent and manage, and which are the formulas, kitchen feeds or nutraceuticals you can have and use safely, and in which conditions you can use, and feeding routes, tubes, tube sizes, all this needs to be known. Measuring and monitoring feeds and feed safety is important, and nutritional adequacy and tolerance are also very, very, very important. So this completes enteral. I'll just take you through the parental and then we'll come back to the case studies. Parental, I'll not go in depth. I'll just take you just a overview. I think most of you, parenteral means it is away from the gut. Enteral is in the gut. Parenteral means away from the gut. And it is called as hyperalimentation also. Hyperalimentation means leaving the stomach. Alimentary canal, leaving the alimentary canal. And just see at this image which shows you different routes of parenteral feeding. The sites, like I'll take you through a next one. So you can see in this picture, these are the sites most often which are used to feed parenteral nutrition. The vascular access, right? It can be intrajugular, extrajugular, or the ports which can be used. And you can use cephalic. The thicker the vein, the stronger. And here it becomes very important to understand the vein strength, because when you're feeding a high osmolar and high viscous fluid, it becomes very important for you to understand the vein strengths also and the lines from where it is being fed, because whatever is fed as parenteral formula directly lands up into the heart. So you should be very, very careful. For example, if you see in the second image on the left side of right side of my screen, left side of your screens or something like that. So if you see that, you can see the roots, like it is delivered directly into the ventricles of the heart. So it can be PICC line, which is away from the heart, or intrajugular and extrajugular veins, or like you can have even the other venous catheter access also. So cephalic veins can also be used, basal veins can also be used, basalic veins or cephalic veins can also be used. If it is short duration, then we use the basalic veins, the short peripheral veins we use. If it is long duration, then central veins are used. Again, depends like how long you want to feed the patient. So peripheral, as I told you, central or peripheral venous access, we take short duration. If it is less than 10 days or less than 7 days usually, or less than 14 days, we use peripheral. But problem with peripheral is if the veins are not good, there is always a risk of thrombophlebitis in the patient. The veins can swell and block, and you can see the phlebitis happening with this patient. Central are safe. The other problem is central related bacterial infections can be on the higher side if it is not managed properly. So centrally, we usually either intrajugular or extrajugular veins are used, and sometimes percutaneously inserted central catheters are used. And in these cases, you can give 100% nutrition. And peripheral is short term; it's limited. Why we use this parenteral nutrition is if patient is not able to eat or should not eat or will not eat adequately. In such conditions only we use parenteral. It is not just limited to disease or surgical interventions or something. It is also sometimes you use parenteral as a combo feed. If patient is not able to take enterally adequate or orally adequate, or if patient is getting prepared for a surgery, pre-operative nutrition, and patient's nutrition status is not that good enough to undergo the surgery, in such conditions we do give parenteral nutrition, not just surgical or something like that. You can definitely you can use parenteral partial or total or central or peripheral can be used. So in case of the prescription is like it can be it is administered continuously, and you can start with the half the estimated calories, and then full proteins can be given. But these proteins in the parenteral can increase the osmotic load, osmolarity of the feeds. So you should be alert if patient is having refeeding. Again, dextrose can have a problem. So depending on the clinical scenario, you should decide which parenteral formula you're going to use, whether you're going to use a standard bag or you're going to use a customized bag. So these things becomes very important, and fluid load is very, very important here, because you are delivering directly. There can be fluid overload if it is not taken care of. And parenteral formulas doesn't come with electrolytes or multivitamins and trace elements because of the stability issues. So you need to supplement them. And if you don't supplement, you are only giving carbohydrate, protein, and fat. There's no fiber available in the parenteral solutions. And some parenteral solutions do come with small amounts of electrolytes. So you should be alert depending on the brand, the volume, the composition, and the elements available in that. Based on that, you decide which one would suit the patient. So you should always take initiative to go through the labs of the patient, the biochemistry of the patients, and then decide how much fluid can be given. And based on the fluid, you decide the volume of the parenteral feed. Then calories, again, lipid becomes one of the most important things. If parenteral lipids are not managed properly, they can result in triglyceride elevation, and hepatobiliary concerns can problems can occur. So it's always good to deliver fat once in 2 days or once in 3 days to prevent fatty acid deficiency. Don't give fat every day for 10 days. The patient will have problems. They can land up in hepatobiliary, or blood lipid levels can elevate. So carefully you should administer. Or parenteral related liver failure can also occur in pediatrics, even adults also we can see complications related to fat infusions. So should be careful whether the patient needs fat, if needs, how much, how frequently, how we are going to administer. Those things should be considered. So kilocalorie increase in case of parenteral, it's not like your enteral nutrition where you decide, okay, I'll add a little bit of sugar or some fat and increase the calorie load, or add some standard formula 2 cals or 3 cals or something like that and make it. That doesn't work out in parental. You need to be very alert how you are going to make the calorie load, because if you add little dextrose, there is a risk of hyperglycemia. If you add more proteins, there is a risk of osmolarity increase, and osmolarity through peripheral line is up to 900, and central line up to 1200 you can give. More than that means you should be clinically sound enough to manage the prevent and manage the complications. Only then you can do it. So continuously it can be administered non-stop over 24 hours, or cyclic infusions also you can do. You have to use a pump and do it. And the other thing is, like, I just had, okay, no, I don't have that bag here. Mm, the cyclic infusion, you can give around 10 to 16 hours infusion you can do, and give a feed break or the administration break. And overnight you can give. Cyclic infusion can give little bit of break for the patient to relax and rest. But in case of continuous administration, you don't give relax and rest. And insulin and heparin can be added to the parenteral solutions. There are few medications which can be safely added to the parenteral formulas also. This is a huge list. You need to be alert about those medications, because some of the drugs can interact. For example, if you plan to give iron through parenteral, you can't add it through the parenteral formula because it has stability issues. So compositions of parenteral should be carefully addressed. You can't add calcium uh, carbonate to the parenteral. You can add calcium gluconate. So like this, magnesium sulfate can be added. Sodium chloride can be added. Sodium bicarb cannot be added. So you need to understand which formula or which electrolyte, which form is safe, and safely it can be added and administered to the patients, so that you don't complicate the uh, patient. Then if you have a pharmacy within your hospital, you can customize and do it. If you don't have a pharmacy, then you need to depend on the standard formulas. And these standard formulas, may protein formulas, or they come in crystalline amino acid solution forms, and 3 to 15% is present. In India, we get between 10 and 20%, but most of the time it is 10% in 100 ml or 10% in 500 ml solutions is what we get. And then the osmolarity of the feed, like I mentioned, for every gram of protein, it is like 10 osmolarity. So you need to be alert about this. Don't blindly give more proteins unless there is a need for the patients. Otherwise, protein and metabolites can increase because of um, because of the high protein one. Second thing, osmolarity of the feed increases, means there can be blood osmolarity also can change. So you need to keep osmolarity as physiological as possible without any complications. Carbohydrates, 5 to 70% you do get even in India also. 10% solution, 5% solutions are most often used. And in case of hypoglycemic event, even 15%, 50% dextrose solutions are used. Depending on the calorie requirement and non-protein calories, you can definitely give them. The max you can use is like 7 grams per kg per day, but in some conditions we do use 7.2, but safe to use 5 grams per kg per day. And if patient is having pulmonary problems and other cardiac issues or diabetic issues, carbohydrate load should be controlled. That is very important. Lipid emulsions, again, soya bean based lipid emulsions, 10 to 20% you get. Readily available formulas, you can go to the pharmacy, pick them up and see. So 10% gives you 1.1 calories, while 20% gives you 2 calories. So you need to understand how many calories and what is the combination. Nowadays you get the SMOF, soya, olive oil and medium chain and fish oils. Fish oils and olive oil are said to reduce the risk of parenteral induced liver uh, failure, and other concerns can be addressed with those. That is what is the project. That is what is projected by the nutraceuticals. Let's hope for the best. Balanced calories can be given in case if you feel that this patient is not getting adequate through parenteral standard formulas. Again, you can add little more to the parenteral formulas without much going in for a second formula or a bag. You can use the available standards, whatever it is, like either amino acids or dextrose, you can add, infuse with the same bag itself. Vitamins, minerals, and trace elements should be admixed and can be given, but in India, we don't have that provision unless you customize it. Most of the clinicians don't accept adding vitamins or minerals or trace elements into the parenteral bag, but you can give it on a separate line. It can be up to the RDA or depending on the clinical scenario or clinical condition or drug nutrients or uh, whatever surgical or medical intervention. Based on that, you can alter more than the RDA or less than the RDA can also be given. So monitoring patients on parenteral nutrition is very important because one is the infection complication, which is always on. So these patients should be kept in a sterile zone, and the feed and whatever the lines we are using, the line of delivery, the IV line should be carefully monitored by the nursing. And even the dietitian should always look for the site. Don't just go near the patient. Okay, parental hai, fine. That is not this. You should go near the patient, check whether the patient is having any infection around the site of parenteral line, whether it is peripheral line or central line, whether there is any risk of phlebitis, whether the feed is flowing properly. Sometimes it so happens there can be a clot and the feed can, because of the clot or something, the feed gets stopped, the flow is stopped. So you need to go closely and observe. And sometimes the parenteral solutions can have sedimentation or they can coagulate also. If they are very old and the temperature change or the heat change or some, because of various reasons, it can coagulate. So it becomes very important for you to go check the parenteral bag also, whether the feed, whether there is any issue with the bag or the line or the patient. All these things should be checked properly. And if there are any instruction changes, that also should be taken into care. So daily weights are very important and input output is very important, and frequent labs and risk of refeeding is very important to be managed in parenteral patients. Blood glucose levels to be checked. And apart from that, whatever the hospital protocol procedures and physician's interest should also be taken care of. Then defining metabolic needs of these patients, especially parenteral patients, the thumb rule is usually 30 to 35 calories based on weight estimates. But we usually start with 20 to 25 calories. We don't start with 30 or 35 calories. We always start with the lower end and then slowly build up based on the tolerance and patient stability, hemodynamical stability of the patient. And patient should settle with whatever complaints, chief complaints they have come, that the patient settled or the issue be resolved, then you go on slightly increasing. We don't use the BE calculations, basal energy expenditure calculations, or Harris Benedict is not used because all these over calculate or overestimate Indian needs. So always go for the best is 20 to 25 calories. You are safe and fine. Respiratory quotient if patient is on ventilator, this is very important. Always monitor respiratory quotient for the patient, how much of oxygen goes in, how much of carbon dioxide. For this reason, at least you should check up the weight of the patient, which is very important. So based on this, you can understand like how much of, assume that 1 liter of oxygen utilized 5 kilocalories, then you can definitely see how many liters of oxygen is going. Think patient is getting 2 liters or 10 liters of oxygen per minute or per hour. Based on that, you can calculate how many kilocalories patient is utilizing. So this is very important. So you can always, most patients in the ICUs, like 80 to 90% patient go into the ventilator. Definitely you can always check oxygen levels also, and how many liters of oxygen is being fed to the patient. Based on that, you calculate how many kilocalories of energy is being expended by the patient. And based on that, based on this calculation, you can always understand whether it is patient is having ketosis or gluconeogenesis, or if there is any, most patients don't get alcohol in the hospital. So sometimes in Western countries depends. If they are on the oral feeds, definitely some may take it. In other countries, it's different. In India, we don't get. So you need to understand the keto fat metabolic point or weight loss point, and lipid peroxidation or fully starvation. Patient is in NPO, then how long the starvation can have an impact on the, how much of impact this starvation can put the patient into malnutrition status. Those things you can calculate. And substrate utilization, if you are giving a substrate like mixed meal for the patient or enteral formula, what impact it will have on the nutrition status of the patient, whether the patient is using it adequately or not. So one should be always less than one. Between 9 and 1 is always good. So if you get a RQ of around zero point 0.9 and 1, that means the patient is fine in an anabolic state. If it is less than 9 or less than 8, if you take, that means patient is in a catabolic state. If it is more than, if the RQ is more than 1, that means patient is getting overfed. We always say don't overfeed the patient. It's very, very important. Don't overfeed the patient. Even if it is a surgical patient also, you need to go slow so that you avoid complications and prevent mortality rate. So to avoid complications and prevent mortality rate, risk of mortality, don't overfeed, go slowly, even if it is a preoperative nutrition and you're preparing the patient for the surgery. As few as 10 to 7 to 10 days is required to make a difference when you feed a patient, especially pre-operative. So what is the time given for you to nutritionally correct the patient becomes a big question here, because sometimes 2 days, 3 days you get, sometimes you may get a month's time. That is a boon. So parenteral intervention in these cases can definitely help the patients, especially malnourished patients and patients who are having poor blood proteins, not just albumin, because albumin, we consider albumin is very much required post-op. This is one nutrient, not from the nutrition, not just from the nutrition standpoint, even from the medications point, because 99% of the medications are bound to albumin for transportation. So drug transportation occurs mainly because of serum albumin, the cytochrome 450, which is very important. Apart from that, even serum albumin is very important because it transports the drug to the site where it has to work. So albumin status means protein status of the patient is very, very important. So correcting albumin and globulin and fibrinogen, because globulin again it's important for maintaining immunity of the patient, immunostatus of the patient, and fibrinogen maintaining blood coagulation parameters. So it becomes very important in pre-operative nutrition status, so that post-operative patient should not get into complications. So within 2-3 days, if you are able to feed a post-operative patient, it is good. Otherwise, again, the patient will get into malnutrition status, or immediate or intermediate malnutrition status. Gut is working, good. If gut is not working, use parenteral. Most of the time, post surgery for day 1, day 2, day 3, usually parenteral nutrition is used. And mildly malnourished patient also, you need little bit of parenteral, may not be aggressive. Peripheral parenteral can be given. So GI surgeries and injuries also parenteral can be given, because if the gut is not working, not stimulating, not absorption is not effective, and if the immune functions are poor, then you can definitely give parenteral nutrition. But with parenteral, most of the time it so happens bacterial translocation can occur. So tropic feeding should be initiated if it is okay with the surgical team and the ICU team, medical or surgical ICU team. And one of the major areas where parenteral is advised always is routine short bowel syndromes, like if your bowel or the small gut is less and surgically removed. And if the length of the gut is less than 60 or 100 centimeters, definitely you are asked to feed the patient parenteral nutrition, because absorption and disaccharides, sorry, what the uh, more than the poly, you get the dipeptones or disaccharides are partially elemental forms of nutrients, will not be digested further and absorbed. To prevent that, usually short bowel syndrome, a parenteral infusion is done, and it is usually done as a rehab program. And patients are trained, patient and patient attenders are trained to manage home parenteral nutrition, and this becomes a problem for them for the life. It's not a days or 2 days, it becomes a problem for life. Then in Crohn's disease also, because of thick inflammation of the intestinal tract, absorption and digestion and enzyme secretions and digestive hormone secretion doesn't happen adequately, parenteral nutrition becomes a choice of management. It is like a sort of medication you go on pre and post, not just operative patients, even non-operative conditions also. You keep giving at least as an add-on dose to manage nutrition status. The other thing is to prevent vitamin D deficiency and calcium deficiency becomes very important in these patients. So IV calcium and IV vitamin D supplementation can be done to prevent bone deficiency, bone diseases in those patients. Ulcerative colitis is also similar to your Crohn's. Here also parenteral might be required in some of the cases if it is chronic. If it is mild moderate, you can manage with enteral feeds also. And some of the ulcerative colitis patients can definitely manage their nutrition status with adequate enteral feeds. But if it is chronic and if there are hemorrhages, perforations, and obstructions, eye output fistulas, forced surgery, in such condition, parenteral becomes a mandate. And the intracutaneous fistulas, where short bowel surgeries and others happen, colon or intestinal surgeries where fecal matter leak happens or any GI secretions are leaked out. In such cases also you can't feed the patient enterally, so you would be going into parenteral feeding. Electrolyte balance, fluid balance becomes very important, and most of these patients would be losing fluids and electrolytes and proteins also, and they'll end up becoming malnourished within a short span of time. So post surgery also you need to manage fluids, electrolytes, and protein status for a long duration. And acute pancreatitis, earlier we used to opt for NPO for 7 days, feed the patient parenteral nutrition. But nowadays we start the patient with an enteral tube, put it to the post pyloric state or ligament of Torres, and then we start giving them enteral nutrition. And it's comfortable and safe, and patients get well and go. If there is chronic pain, in case of acute pancreatitis, you will have abdomen pain. If it is very chronic pain and patient is not able to tolerate, has nausea, vomiting conditions, in such cases you may think of parenteral nutrition. So adequate hydration is very important, and pancreatic secretions, especially the pancreatic enzymes, the exocrine part of the pancreas may not be adequately synthesizing enzymes. So don't feed the patient aggressively. Go on with the tropic feeds or minimal enteric feeds, small quantities of feeds, maybe 20 ml, 30 ml over an hour, 10 to 15 feeds in it. The quantity might be small, so that keeps things much better. Not like patient is having problem. You overfeed the patient will not work out because the enzymes are not being synthesized or they might be contaminated also. Depends. So blood sugar monitoring becomes important because these patients can end up becoming temporarily diabetic. Sometimes they may become permanent diabetics also. And malignant diseases like cancers and others, malnutrition condition, cancer and malnutrition are, it's like hand in hand, buddy buddies they are. So complications of starvation and chemo surgeries, all this can put the patient into a cancer related malnutrition. So from the day one of diagnosis, managing these cancer patients is very important. So you need to see that you prevent patient going into malnutrition. First find out the cause, the site of cancer, and how that will have an impact on the nutrition status. Then what is the treatment modality being used for the patient, how that will have an impact on the malnutrition status of the patient, and what are the medications, what is the age of the patient, what is the stage of the cancer which is diagnosed, there, etc. There are many such things which you should look into before deciding on the nutrition. It's not just cancer, a high protein, high calorie, high fat, antioxidant, neutropenic diet, all that doesn't work. You need to look into every fine, precise factor and then decide the nutrition which you are going to give and the nutrients which you are going to give. The preferred route of feeding is very, very important. So involving the patient and patient attenders is always important in these conditions because it is a psychological trauma for them. So it's very important. Then traumatic brain injuries, most every second, third bed of the hospital will come with traumatic brain injury due to accidents, road traffic accidents or fall or something like that. And in these conditions also, if patient is fine and good, fine. Otherwise, you may start with an enteral feeding. And if patient is not in a stable or quick recovery state and they'll end up in multiple complications or injuries or severe traumatic brain injuries, what we, in such conditions and patient land up into hypermetabolic state, then you may land up giving the patient parenteral also for short duration. Burns also. Burns is also very important. Burns may you need to maintain hydration. You need to maintain protein status because hepatic protein albumin synthesis becomes a challenge here. Since skin is burned, the body surface area, skin burn, percentage of the skin burn can complicate because skin is one of or the dermis layers of the skin is burnt. Albumin synthesis is affected, and this effect will have a problem of drug delivery and recovery, fluid management, and electrolyte. Because your albumin is required for managing fluids and electrolytes and medications, also drug transport, like I told. If this is disturbed and if hepatic or the liver doesn't support adequate albumin synthesis, then the patient may not recover faster. So it becomes important for you to see that you give adequate nutrition, adequate protein status has to be managed. So always parenteral would be a preferred choice usually. And from parenteral to enteral, the transition becomes very important. How you transit, because sometimes it so happens you just remove the tube. I've seen in many of the hospital cases where parental patient is eating fine, patient is oriented, hemodynamic stable, remove the tube and give oral feeds. You forget if the patient is on a long duration enteral feed, patient would have forgotten the swallowing reflex. There would be a problem with the swallowing. So you should always test for the swallowing, see how comfortably the patient the feeds and slowly change it. Give 50, reduce 50% of the enteral feed, start orally once without having any swallowing issues or any pain while swallowing and no pocketing of food orally, all these problems, then you can completely transit to enteral feed. Parenterally also, when you are starting, at least taper, slowly go on tapering by 50%, 70%, and then you stop it. It's not like you stop, okay, patient is eating or you transit to enteral, you stop off. Not like that.
Shobha ma'am, are you online?
Lakshmi, I think there is problem.
Ma'am, I will just call her once. Ma'am, she's coming back. Some connection problem for her.
Okay, Lakshmi.
Lakshmi, can you ask her to address the questions?
Yes, ma'am. She's coming back now, and she's going to wind up only. I mean, questions will be.
It's almost 6.
Yes. She joined. Participants, some technical problem for the speaker. She's coming back and summarizing the session. Then we will take up the questions. Thank you. Wait. Hello, Shobha ma'am. Ma'am, kindly unmute, no? Unmute your audio.
Yeah, sorry,
Ma'am,
had
yeah.
some net connection problem again. Sorry for that.
No problem, ma'am. Ma'am, can we go to the questions, or you would like to summarize?
I'll just close that.
You
You
can
can
just
summarize.
summarize the thing, ma'am. Then we will go to the questions. Yeah.
Okay, fine. It's okay, fine. We can start taking up the questions. You are able to get the slides, I think.
Okay.
Yeah, with that, I would like to close. I think they have a lot of questions.
Yes, ma'am. Lot of questions are there. Yeah.
Yeah, we can take. I would like to take up the questions.
Okay. So thank you, Shobha ma'am, for that knowledge sharing presentation. You have given
Thank you, sir.
that good insight to different case scenarios of enteral nutrition. It is a vast topic. Definitely, it needs some time to cover the whole, both enteral and parental nutrition. Since the time is less, we will just go
Yes,
to
yeah.
the question and answer session. Yeah. So
Thank you. Yeah.
okay.
You can share with the questions.
Ma'am, you can just go to chat box and see I can also read.
Yeah,
Oh,
let's take it
uh,
up. Okay, just close this sharing of this meet.
you can close the screen, I mean, share the screen, ma'am. Okay, ma'am, shall I ask the first question?
Yeah, yeah.
Okay. Ma'am, one question is, are hospitals encouraging kitchen formulas?
Yes, most hospitals, I handle around 25 hospitals on my telemedicine, all ICUs itself. Hospital may most hospitals are it is kitchen based formulas, but of late because of the pharmacies and some of the doctors coming from abroad and some are very particular, it's an understanding between the pharmacy, I shouldn't say this, it's an understanding between the pharmacy and the doctors. Sometimes you'll end up going for the standard formulas also, but it is 99% kitchen based formulas.
Okay. Then continuation of that question only. What about infections caused by kitchen feeds? Can you share one kitchen formula?
uh, Infections from kitchen based formulas can be seen because it depends on the persons who are handling the feed, who are preparing the feed, especially the feed delivery boys, the cooks, and if they are infected, if they have some infection and they come, the cough or something like that, and the counters which they prepare or the equipments which is used, the formulas which is used, if it's not prepared, there are risk of contamination. But kitchen based contamination related diarrhea or GI disturbance are minimal in the Indian scenario because they just prepare, cook, and deliver it. So in that condition, we see minimum of them, maybe 1 in 100 or something like that. It's not like kitchen-based formula. You can prepare anywhere from all the 5 food groups or your 6 food groups, based from your cereals, millets, or vegetables, fruits, anything. Even a simple fruit juices, your tender coconut waters, your cereal porridges, your malts, your veg soups, many of these can be used, and we use them routinely because they're very close and physiological, and that your body accepts it better and they better digest, better tolerance will be better.
Okay.
So for that purpose, we use the kitchen-based feeds itself.
Okay.
Okay.
Another question, ma'am. Since the patient is on palliative medicine, that this is one of the first questions when you presented the case, no, ma'am, that time,
Yeah,
right? Since the patient is on palliative medicine, can we alter the RDI accordingly?
yeah, definitely. None of the patients come with the RDA prescriptions. Whatever you take any patient who comes into the hospital or into the ICUs, we don't fix to the RDA, recommended dietary allowance for energy or proteins, or it is modified according to the clinical, medical, or treatment modality of the patient. That day's systematic need of the patient according to that scenario, whether it is medical, surgical, or clinical. Based on that, we alter the RDA. It's not fixed to the RDA unless patient is walking, talking, and eating. So RDA is just a base. Based on that, you build up your nutrition or you increase or decrease the nutrition.
Thank you, ma'am. Another
Yeah.
question, is there any standardized kitchen formula that can be referred?
Standardized kitchen formulas means each hospital settings will have a different. That depends on the head of the institute. Head of the department. They formulate the kitchen feeds or the some used blenderized soya based, some use casein based, some use whey protein based, some they have a standard whatever is prepared. So that is dependent on the hospital and the dietitian, whoever leads the team or whoever formulates the feeds. There is no fixed standards actually in India. Currently, we don't have a fixed standard protocol where we say, yeah, this has to be given, this should not be. That is not available.
Okay. Thank you, ma'am. Another
Yeah.
question. What should be safe GRV before the next feed in PEG and PEJ diets? And what should be the pH of the gut? Any protocol?
See, jejunectomy feeds me, we don't take the GRV, gastric residue volume. We don't test because it is jejunal, you can't pull it back. Gastric side, especially if it is a nasogastric or percutaneous gastrostomy feeds, in that we always see that the feed should be less than, or if it is not there, or less than 50 or 100 or something. Whatever you have fed, if it is less than that, then it is safe. If, for example, if you have fed 200 ml to the patient, after 2 hours, if you go back and check, If the feed is around 200 plus the gastric secretions of 400, 500, then we don't usually feed the patient. We hold the feeds for some time. Maybe that feed, the immediate feed would be withheld. And next feed, we are going to recheck the gastric volume and then feed the patient. If the residue is less than 50 ml, if you have fed 200, if it is less than 150, then you can definitely feed the patient. Jejunostomy sites, there is no gastric residue volume test, one thing. pH of the feeds, usually it is not monitored, but if it is around the body pH, the body fluids and alkaline pH, then it is good.
Okay, thank you, ma'am. Another question. In conditions where fluid restriction is required, wouldn't fluid-based formulas further increase the risk?
No, because we are controlling the total fluid. See, if there is a restriction, think if a patient needs around 1600 ml as a standard RDA, and if the restriction is around 1000, restricted to 1000 ml, then I'm going to concentrate on 800 ml of the feed, not 1000 ml. 200 ml would be the tube patency medications. And if there is some IV medications dilutions, that also we take into consideration. So 800 ml I'm going to give the patient. So it will not cause problems to the patient.
Okay.
That is your basal requirement, because you are 300 ml of invisible loss, 300 to 500 invisible loss, and output of around 500 to 800 output is there. Urine output is there, 800 ml should be fine. So you modify it according to the patient need.
Okay, fine. One question, ma'am. What kind of fatty acids mostly allowed in PN feeding?
Parenteral nutrition may fatty acids is what the standard you get. SMOF is fine. Of late, we are also using the same. And if it is a 3-in-1 bag, which comes in, like it comes as a standard, you can't alter, then it might have a problem. But most of these are phospholipids and mostly these are phospholipids only, phospholipids and medium chain triglycerides which are present. And fish oils also are added to this, which can prevent fatty acid, liver related problems. But PNMA, you can't modify the fat. What you get from the pharmaceutical company is what you can use. So there is no choice for us.
Another one question, ma'am. What could be the usual duration of keeping the patient in TPN?
TPN, that depends. It can be a lifetime problems also. It can become a lifetime problem. There are cases which we are handling lifetime problem ho sakta hai. But in hospitalized patients, if it is a short duration, it can be for 3 days, 4 days. We have patients where we give for 1 day also, because we don't want any malnutrition for the next day. So we give for 1 day also, we give for 5 days, we give for 10, we give for month also. And sometimes it can be a lifetime problem also. Depends. If there is a total gut failure, and a major gut resection happens, in such conditions, it becomes a lifetime problem for the patient, and lifetime they will be on parenteral. So it's dependent on the clinical and medical situation or surgical intervention of the patient.
Okay. This one question, ma'am, one student asked, will there be any long-term effect on the weight of the patient if this type of nutrition is continued for a long period of time, especially in case of surgery?
Depends. Weight effect can happen if the patient is not fed adequately. Patient can start losing weight, what we call as hospital-induced iatrogenic malnutrition or hospital-induced malnutrition, that depending on the treatment and surgery or clinical. Long duration parenteral feeding can also have an impact on the weight and fluid status also. And if you are overfeeding the patient, definitely it can impact on higher weight gains also. If you're giving more fluids, because it is a fluid based feeds, whether it is enteral or parenteral, fluid retention can also occur, and fluid overload status can also become a weight problem. But weight gain in these patients, if it is short duration feeding, it will not show up. If it is a long duration feeding and you are overfeeding the patients, then definitely you are going to see a weight change in the patients. And if you're underfeeding, definitely there will be nutrition risk, like patients can go into malnutrition. Again, the metabolic, like hypermetabolic, hypercatabolic conditions also, that can also have an impact on the weight of the patient. Depends. It's not, nothing is a fixed parameters in medical science.
It's on case.
Yeah, it's on case based.
Thank you, ma'am. One question, ma'am. Can you just tell some of the conditions where the internal and external jugular vein is chosen as the site for providing the nutrition? some one or two?
Parenterally, internal, external, long duration feeding. For example, if a patient is having diffuse axonal injury, traumatic brain injury, patient in semicomatous or comatose state, you can use a central line. If there is a total hepatic failure, total renal failure, total GI cancers like gastrectomy patients, and patients who would have consumed some corrosive materials where the stomach needs a rest for longer duration, even cardiac failure patients, many cases we use central lines. And ICUs may to every second, third patient will be on a central line, either intrajugular or extrajugular. So central lines are the most frequently used with 2 or 3 ports, depending, one for the medicine, one for the fluids, and one for the parenteral we use like. So central line is not fixed to case. If we feel the patient made for traumatic accident also, road traffic accident, which is very chronic, patient might be having multiple fractures, patient is not stable and has brain surgeries or craniotomy or craniectomy, something like that, which may take longer time for the patient to recover. In such conditions also, central lines are used.
Okay.
On long duration, we use them.
Ma'am, one question. How would you ensure the nutrient delivery in a blenderized feed? Is the all the goals are met in that type of a feeding?
Especially blenderized, may you pick up foods from all the food groups. Yeah, cereals, pulses, vegetables, fruits, oils, milk, everything. All the 5 food groups you have to add. And each feed, you should see that you balance the entire thing. If you go back and calculate, I always make my students go back and calculate the basic steps, like take the calories, calculate the carbohydrates, proteins, fats, and then calculate the food groups also. And taking these food groups into consideration, then how much of cereals, pulse, vegetables you give, take all this into consideration, so many grams of cereals or so many grams of pulse, then you divide that into each feed. Per feed, how many grams of cereal should go, pulse should go, and vegetable should be there. Take that all, then only then it will become a balanced meal, or you will be able to provide the nutrition to the patient. That is one thing. And day 2, day 3, we always measure the mid-arm circumference of the patient and see if there is a weight loss we can make out from that, or the temporal part of the facial muscles, temporal and other things. And when we start seeing these parameters, we can definitely understand whether the patient is losing weight or not. So whether nutrition is adequate or not, and recovery of the patient, stability, how fast the patient responds to you, all those things. There are quite a lot of signs and symptoms which we can take into consideration, especially nutrition focused physical findings, what you see when you do nutrition assessment. Similar to that, you can do for nutrition tolerance and betterment also.
Actually, ma'am, that was one of the first question in the chat box. If you can just show how to calculate the calorie protein content of, for example, in some case scenario, because most of our participants are students also. So, but now the time is up only.
I'll do one thing, I'll share. I'll ask one of my students to share it with you people, like the entire steps and calculations, plus how we arrive at a diet, either an enteral or a parenteral. I'll share that document with you people.
Mary
Maybe
ma'am,
that you
can you
can.
just tell your position, ma'am? Mary ma'am, are you there?
Yeah, I'll share with you people so you can definitely circulate and use it, because there are at least around 13, 14 steps we use. But since with experience now, just by looking at the patient at the 2000 calories, we'll be knowing how much to give. 2000 calorie, 400 grams of cereals, then I like 100 grams of pulse. Then that becomes with practice. But initially, when learning, you need to learn by calculating the weight, height, and other things. So that I'll share that document because it's a little tedious process.
Okay, thank you.
Yeah. Actually, Mary ma'am only asked that question. So she,
No problem. I'll share that document. Definitely, I'll stay.
this is actually the continuation of that question I asked, like blend rice feeding, no, regarding.
Oh,
So once blend and strain, how to meet per feed goals?
per feed goals means, see, if I say patient needs 1600, and if you're planning 8 feeds in a day, the feeding hours of 16 hours, if you take second hourly feed, 200 ml you are giving. So 200 ml, 1600, 1 kilocalorie per ml will become the standard. So 1600, 200 ml second hourly you give, and 8 feeds you give, it becomes 1600. So 1 calorie. So 200 ml, you should be able to meet 200 calories. to meet 200 calories, how many grams of cereal you need, how much of pulse you need, how much of milk or milk constituent, or if patient is non-diabetic, how much of sugar you are going to add. So all that you can plan up. Actually, we have a standard plans which we teach when we are training the clinical dietitians and critical care dietitians. We make them do all this calculation. Take every food ingredient, see how much the consistency can be, because after cooking, the consistency and the weight changes, and the water hydration of that feed also changes. So we make them prepare those charts and practice at home and see different feeds so that it becomes easy. If you have kitchens in the hospitals, we can definitely do that. So I always see that the amount of cereal or the pulse which the patient needs, that much is met per kilocalorie or per ml. Based on that, we calculate and decide and do. Whether it is blend-raised or hospital-based or standard formulas also, we take all these ingredients and the calorie value per ml. Take that into consideration and calculate that.
Okay, one last question, ma'am. How
Yeah.
many calories are recommended for hypermetabolic phase of critical illness?
Hypermetabolic, it depends. If it is a pediatric patients, it will be like 100 to 110, 20, sometimes even 200 calories we can give. Depends. But if it is an adult patient's max to max is the max I've given is like 50 calories per kg body weight, with your standard being 30 calories. 50 calories is the max. Beyond that, I don't allow, because either you may increase the carbohydrate load or you may increase the protein or the fat load, which may become intolerant to the patient. So the max to max is always keep 35 to 40. 40 you keep, don't go beyond that. Otherwise, if required in conditions like burns, cancer, and you can go up to 50 kilocalories per kg body weight.
Okay, thank you, ma'am. So I think we have come up with most of the questions. So thank you once again for spending
Yeah.
the time with us, for sharing the knowledge regarding enteral and parenteral nutrition. Okay,
Thank you.
yeah.
Thank you.
Okay, thank you, Dr. Shobha. It was a
Thank
very
you, madam.
informative and educative session for the students and for the dietitians. You have taken from the ground and you have gone up, you know. So, as you said you will also share the calculation with us. It will be really good for our students. Okay, so if you can you share your email ID? We can share in the chat box so that if they have any
Yeah,
questions,
yeah,
they can
sure,
ask.
sure. I'll type it in the chat box itself. If they have
Yes,
any
please.
Yeah.
So some
me,
questions which were not able to take it up, they can
yeah,
ask
yeah, sure.
questions so that you can, because this budding nutritionists, they have a lot of
Yeah,
questions
true,
to
I
in
understand.
their mind.
True.
And it is very technical also. This particular session is very technical session. So they
Yes.
have to get the queries to, to be
Yeah,
answered.
I
So,
understand.
yeah.
Thank you, ma'am. I've
Okay.
shared my email
Yes,
ID. The
yes, yes,
problem is like what I feel is the academic part of it, what you teach is the foundation. But
yes, yes.
how to use it, apply it in a
Yes.
clinical aspect practically is where they become handicapped.
Definitely. Theory is
Okay.
taught here and the practical, no, the
Efficacy is a
knowledge they get
problem.
from the hospital. Yes,
Yeah.
definitely.
So you can pull up some dietitians to train them practically what is being done. So that helps the students, I think. And
Yes.
internships also, like what hospital based internships also, they get to learn a bit of it. But critical care is one area where many dietitians don't get to learn practically.
Okay, fine.
So we do train like 2 months training we do in critical care nutrition also. We take just 2 or 3 dietitians and take them from the base of the calculation, how to create the formulas, how to decide on the enteral or how to decide on the parental based on this, how to based on the clinical scenario, which formula, which nutrient, which food, which drug, all this we will teach them over a period of 2 months.
Okay,
It's a
that's
certified from the from our hospital, institute. So those interested can definitely approach us. We do train also, or if it is a big group, so we can make provisions to teach also, because some of the sessions are handled by our doctors also,
okay, 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 fine. That's really good.
and they
We'll
get
get
to
back.
understand the ICU scenario also. What is ICU? What are the equipments they are used? What type of cases they come into the ICU? And how it's not like a diabetic diet, you counsel on the OPD, give a weight chart. That doesn't happen here, because all these patients come in a bed. The patient may be able to communicate, may not be able to communicate. So you need to be very clear. Like you treat a patient, it's intervention based thing what you do there. So hands-on experience becomes very important. Even trained, experienced dietitians do come to us for critical care training.
Okay.
So those interested can definitely let us know. We can make a
Yes, ma'am. And you
arrangement for that.
will also put it across to the students. Okay. Thank you. Thank you,
Thank
Lakshmi,
you so
for
much. Thank you.
moderating.
Thank you, Lakshmi.
Thank
Thank
you
you,
for
madam.
moderating.
Thank you.
And,
Ma'am, I
technically
have posted the feedback link for today.
Yes, yes.
You can just tell participants.
Yeah, participants, the feedback link is here. Please fill in the feedback link. Okay. It will be
Thank
there
you,
for
madam.
5-10 minutes. Thank you, Dr. Shobha.
Thank you, madam. Thank you.
Ma'am.
Thank you.